Okay, so going to go ahead and get going. It's Friday, it's great weather, so you need to be out and about, I guess. So welcome to the first grand rounds of the Department of Medical Education. Some of you may not be aware that we created a new department within the College of Medicine focusing on medical education. There's a number of talented junior, mid-level, and senior faculty who are part of it, along with our staff who are dedicated to training of our medical students. So we decided that we would start the process of having these monthly grand rounds related to medical education topics, and we will sort of have various topics over the years, over the next year or so. The next 6 months have been planned out, and we'll provide that information for the next 6 months and then in the next month or so as well. So welcome to our first grand rounds, and as the chair, I sort of volunteered to do the first one. So we're going to talk about professionalism, and it's a fairly important topic, and it sort of gets talked about in hallways and in various private conversations, but we really never sort of talk about it in the context of what the literature support for it and what does it really mean. So I hopefully in the next 45 minutes or 50 minutes, what I would like to do is to give you an overview of how in medical education people are thinking about professionalism, how we're thinking about professionalism, the impact it has on our learning environment, and why it matters. And I think if you go out of here with the understanding of why it matters, I think I would have accomplished what I want to do. I have no commercial disclosures. I serve as a director of the American Board of Psychiatry and Neurology, which does not have any conflict associated with this presentation. So the first step is to really sort of outline what I'm going to discuss in more detail. And again, I'm going to talk a little bit about professionalism and the learning environment, both in training and in clinical practice. I'm also going to spend a few minutes talking about humanism in medicine, because it's directly correlated to professionalism and how it sort of makes our life a little bit better and a little bit easier if we are better humanistic physicians, and of course it impacts patient care hugely. I'll also at the end go over the UT professionalism policies, as well as sort of outline some of the mechanisms we have to address the issues. We certainly are not perfect in our capacity to sort of monitor the learning environment, but we certainly are at a better place than a lot of other institutions are. So I'll show you some data related to that. So what are we talking about? What everybody sort of uses the term professionalism. What does it typically mean? And the standard definition that is used is that it's a demonstrated commitment to carrying out professional responsibilities and adhering to ethical principles. So that's a pretty sort of basic definition. Most of you who are practicing or are involved in medical education or in any sphere of life are either professionals or working towards a professional degree. And professionalism is an important core attribute that you will find in the business school, in law school, or in medical school, and in our daily lives. And it is becoming more and more important for a variety of reasons that I'll talk about. As far as for trainees or students or residents or as physicians, it's a core competency that we have to not only sort of develop, but also assess as we go along. And I will talk a little bit about that. And about 20 years ago, there was a recognition in the medical community that professionalism was declining. And there was a clear recognition of the fact that the patients were complaining about physician behavior, consistently. There were errors, patient safety issues, and a lot of it could be at least attributable to some extent to how we interacted with each other, with patients, and with our environment. And so in 2002, the American College of Physicians, the American Board of Internal Medicine, and a number of other organizations started putting down some core principles. The AMA Code of Ethics had been there for some time, but these were sort of specific guidelines that were developed. And the fundamental principles which all of us adhere to, whether we know it or not, is primacy of patient welfare. That's our first job as a physician, is to be responsible for patient care. We also have to have clear understanding the primacy of patient autonomy, that we are not going to do anything that's going to be harmful to the patients or do things that the patient does not want. And of course, social justice, which is a fairly large umbrella term, and we don't really have time to discuss, but it is critical. Some other attributes that have been listed, and again, this is sort of a lot of long lists, and we'll make this presentation available to you. But the idea behind is to recognize different aspects of professional functioning. These include your competence, honesty, confidentiality, appropriate boundaries in relationships. And on the right-hand side, things like improving quality of care, access to care, just distribution of resources, managing conflict of interest, professional responsibilities. And scientific knowledge, which when we are studying for tests and we're sort of trying to get through exams, becomes the most important thing. But in reality, that is not the most important thing. It is an important thing, but it is not the most important thing. And in fact, as you get older like me and get grayer hair, you'll realize that knowledge is one part of the equation of being a physician. It's not the only part. Now, you can't fake being a doctor and you not be a terrible clinician, but at the same time, knowledge is important, but not necessarily the only key to being a good physician, and we'll talk a little bit about that. David Stern, who actually was a degree recipient, honorary degree recipient here some time ago, put this sort of foundation for professionalism, and sort of his way of thinking about professionalism, in which the foundation was laid by obviously being competent clinically, having the communication skills and the ethical and legal understanding. But there are aspects that really played a key part were empathy, altruism, accountability, and humanism. And that's what makes us different from a lot of other professionals, in our ability to put our own put comfort aside when we're called in the middle of the night to evaluate a patient, to put our things on hold for others. And that's the critical part of being a physician. Now, interestingly, this is a paper that just came out a short while ago, and it asked program directors, this is a paper from Germany, asked them about what they wanted in their first year residents. What are the key characteristics that they desired in their residents? And there's a big list here, and I've highlighted your medical knowledge piece as being important, but this was sort of the actual numbering of that list. And the first was responsibility. Somebody you could trust to be responsible for tasks. Somebody who's able to consistently do what they're expected to do. Understanding their own personal limitations, being able to work in teams, having empathy for patients, not sympathy, but empathy, necessarily sympathy, but empathy. Being organized, being able to deal with mistakes, being an active listener, and having good communication skills as well as ethical awareness. Number 8 on that list was being scientifically and empirically grounded method of working. Now, I've said this a few times. The implication is not that you don't need to know a lot of things to be a good physician. That's not the point. The point is that along with that, the other characteristics or qualities are equally and in some cases more important. And clearly the program directors are looking for people who have these before they look at necessarily the scores or other things that identify your level of medical knowledge. So the learning environment that we talk about, or I mentioned briefly, is a number of different things. It is typically a responsibility of us as medical educators to recognize what constitutes that learning environment and how to deliver care in that environment with students and residents, and make sure that the environment is conducive to learning and teaching. One of the terms that you'll hear me say repeatedly is the hidden curriculum. And the hidden curriculum is a term that was used quite a while ago, but has become used more often. It refers to something that I can give you an example of. So I'm giving you this talk on professionalism, it's all fine, sort of a lot of detailed information, but then I go on round with Dr. Humayun in about an hour, and I start yelling at him, or I mean to the patient and so on, and the students and the residents who are working with me go like, what's he talking about? And that's the hidden curriculum. So if you're not behaving as you're teaching or you're talking about, so that is what the hidden curriculum is. And this is where the problem is. So we may talk the talk, but we don't walk the walk. We don't behave in a way that's conducive to a good learning environment. And then people learn negative things from that experience, and that leads to other problems, which I'll talk about in a minute. So I'm going to switch gears, and I'm going to sort of outline some of the basic concepts of humanism. And again, it's sort of a fairly abstract concept, but humanism is defined as a combination of skills and knowledge that are used in a respectful and a compassionate manner with clear sensitivity to values, to autonomy and cultural backgrounds of patients and their families. And this is an example of a quintessential healthcare provider sort of being sort of the calm person who is knowledgeable but at the same time has communication skills. Another paper from academic medicine asked students, residents, faculty members at a school, at a medical school, to identify traits that they thought identified humanistic physicians. And these were some of the lists that they came up with. And the number one on that list is humility. This is critically important in an era where we have a lot of role models who do not show humility. It is very important that you recognize that actual physicians who earn awards for humanism, who are recognized by their patients as being wonderful physicians, are humble at the onset. They have an innate curiosity. Their standards of conduct are very different from what you would see otherwise. They treat patients, not just disease. And this is very important. You have a lot of students and residents in the room. Something that really irritates me, amongst many other things, is when people say, room 55 has this problem. Room 55 does not have the problem. Mr. Smith has this problem. So even how we word things is important. How we treat people in that situation is important. People are not diseases, they are human beings. Ability to self-reflect, connect with others, not just patients, but with others, and being good role models. And this will come back quite frequently. Typically, professionalism is defined by the role models for trainees. So the role models are critically important in this process. And again, mindfulness and achieving balance. Now, one of the things that has happened over the years that people have realized, and I'll talk a little bit about burnout issue, is that you can get really into this and become Mother Teresa. But a lot of times people have difficulty being able to do that and maintain a stable relationship at home or have an ability to work on their own. And this also is important. So it's not just taking care of other people, but just taking care of yourself as well. And a term of empathy is defined in the dictionary as the ability to understand and share the feelings of another. And there's an interesting paper that showed that people who were, or physicians who were considered empathetic, actually patients reported more symptoms to them. They had better diagnostic accuracy. The patients were more receptive to illness-specific information and had better compliance and adherence, as well as satisfaction. So clearly there's benefit for all of us being able to function as more empathetic towards our patient, because it not only improves your performance, but it also improves outcome. So now, we're going to talk a little bit about accreditation. I'm going to take this out before LCME comes. So in addition to all the good things, all the right reasons to do this, we're mandated by our accrediting bodies, because we don't really do a very good job of policing ourselves quite often, that we have to maintain certain learning standards and learning environment standards. And there's sort of 2 paragraphs that are fairly long, and I'm just sort of summarize some of these things. But these are important to know, especially for faculty in the room. So medical school should ensure that the learning environment is conducive to ongoing development of professional behaviors. It's respectful. It's our responsibility to have periodic assessments. We need to develop and conduct policies to enhance both positive things and mitigate negative influences, and promptly correct any violation of professional standards. We are also required to define and publicize these standards, and this is what we're trying to do as a small step. You get emails, students sometimes, about professionalism, and that's the reason for it. We need to have effective written policies. It's okay to say all this, but if there's no process in place, then we have issues, and I'll talk a little bit about that. Effective mechanisms for prompt responses. The mechanism should be well understood. In fact, one of the questions for the medical students in the room, when you do your graduation questionnaire, you're going to be asked if you understand how to report a professionalism-related issue. And typically the responses have been mixed in that. Although we've had improvement, there are times when students actually do not know, and it's our fault if they don't know. And the complaint should be investigated without fear of retaliation. As you know, the university has a policy. Our policies clearly state that there should be no retaliation, and that's our job to prevent that from happening. The ACGME revised its program requirements. For those of you who are involved in residency programs, ACGME has core program requirements, and as well as certain things that are standardized across all residencies and fellowships. This is one of them. There's 6 sections to it. The 6th one has been revised, and I put this sort of long, detailed explanation because it sort of talks about the core of what we're talking about. I served on I was fortunate enough to serve on the Neurology Residency Review Committee for 6 years, and one of the things that I was used to struggle with, because I came from a medical school background, so I was aware of the learning environment. Prior to this revision, there really actually wasn't anything about professionalism in the ACGME standards. And we had programs that clearly were suboptimal in terms of performance in that field. The residents were complaining about the unprofessional behavior, but I could not find enough ways to give them citations for it, but we did manage to do that. But now there's clearly statements in there that talk about professionalism similar to the ones that we talked about. And the ACGME, and this is their explanation for the change, is committing to addressing physician well-being for individual as it relates to the learning and working environment. The creation of a learning and working environment with a culture of respect and accountability for physicians' well-being is crucial to physician ability to deliver the safest, best possible care to patients. So again, clearly outlining that there needs to be clear policies and procedures in place, as well as role modeling. So why are we talking about this? Is this a big deal? Not a big deal. I'm glad there's so many people in the room because it is a big deal. There is a lot of evidence to suggest that the learning environment is not as good as it should be. And I'm not talking about here, but nationally. There is evidence of impact on training, impact on practice, and the phenomena of burnout that I'll talk about as well. If you look at, there's a large study that was published about a year and a half or about 2 years ago in 2016, which was a meta-analysis of incidence of depression in medical students. And the numbers were about a third of students meet the criteria for depression. These were, of course, screening tools that were used. About 11% of the total population had suicidal ideation, and only about 15% received psychiatric treatment. So significant number of students who had underlying problems. And this was not just in the United States. This looked at South America, it looked at Asia. So they reviewed all studies that had been done on depression, and there are quite a lot of studies. So again, a situation that is concerning. Then a paper came out last year that that was supported by ACGME, by Tom Naska, who's the head of ACGME. And it looked at suicides or causes of death in residents. And the most common cause of death in resident was suicide. Now, as a headline, that sounds pretty awful, but in reality, it was no different from the control population for that age group. So the number of suicides in residents were not any higher than others in people not in medicine, but it was the most common cause after cancer. And the likelihood of committing suicide in residents is typically, when do you think it would be? Intern year, so first year. So typically around this time in their first year of training, when they've had a lot of experiences and they're really struggling sometimes, and that's when it is likely to happen. So again, there is significant issues with that. Now, there are a lot of other studies that have shown a significant number of students and residents complaining of mistreatment. If you look at the WMC graduation questionnaire, about 15 to 20% of students across the nation report some type of mistreatment. Now, the mistreatment may be a perception in some cases, but clearly does happen in others. The most common form is public humiliation. Others are gender or racial discrimination, which is a very serious issue, as well as harassment. Those are the three that were the most common. And this may be hard for you, for some of you in the back. There's a lot of seats up here. If you want to come, it won't disturb us, that's fine. In this particular study from academic medicine that was in 2014, the incidence was quite high, anywhere from 50% to 60%, which was, to me, seemed a little high, but they looked at a combination of studies and showed that the numbers were fairly high. So harassment was the most common, verbal abuse, gender discrimination, academic discrimination, sexual or racial, as well as even physical violence towards trainees was also noted. So these are, again, very serious issues that occur. So what does this do, besides all the personal trauma that it, or emotional trauma it causes? So there are defined empathy scales. There's a Jefferson scale for empathy, which is a validated scale. And the higher the number, the better your empathy score is. So when students enter medical school in the first year, their scores are about 113 or 118 or so. This is gender-based, so male versus female. Females always score better, by the way, in most of these scales. So it's 118 at entry, and it drops by about 7 points, which is quite a substantial drop, and about 9 points for men. And this happens in the third year of the medical school in the clinical environment. So clearly, we as physicians are doing something to students that are making them less empathetic. There's no question about it. Whether it's the mistreatment, whether it's the role modeling, or it's all of the above. But there is something happening across the board that's causing this to happen. And that's why talking about it is important and dealing with it is critically important. Also occurs depending on subspecialty choice. So people who are going into technical specialties with less patient contact have a greater drop, but drop as others drop as well. In fourth year, it does pick up a little bit, never returns to baseline. So you start off with people who are really motivated and are interested in well-being of patients. but they're losing it somewhere along the path, and we're doing it to them somehow. Similar sort of story, this is another large paper that looked at that and showed exactly the same difference. And the loss is sometimes more and underrepresented in medicine, who sometimes may have other discrimination against them that may lead to that. And this paper came out day before yesterday. I forwarded it to Dr. Duggan from Stanford, and it looked at disruptive physicians. It looked at the characteristics of disruptive physicians. Males more likely, surgical specialties more likely, most common occurrence was in the OR, and they also looked at trainee who had disruptive behaviors, and they were from the similar departments. So this is one medical school, and so take it for whatever the limitations it may have. But again, if your role models are not good, you're going to have trainees who are going to behave, unfortunately, in ways that are not appropriate. But it's important to recognize that punishment is not the only solution. Suspending people or sort of doing other types of punishment is not the only solution. There are some systemic issues. There are other reasons for frustrations that have to be addressed from the standpoint from administration and so on. However, that does not excuse behavior. So that's sort of something that is important. And this was sort of hard probably to read, but again, the point I want to make here is that the hidden curriculum drives a lot of this sort of decline in empathy, and it does impact both clinical practice and how students and trainees come out of training programs. And we'll talk a little bit more about that in detail. So the next thing that happens that we've stumbled upon over the last 10 years or so is physician burnout. And it ties in very clearly with decline in empathy, unprofessional behavior, but it is a bigger problem than just that. And there are a lot more other people who are experts than I am. But certainly, sometimes we look worse than the patients for whatever reason. And what is burnout? And burnout is defined by these three characteristics: emotional exhaustion, feeling of cynicism and detachment, what's called depersonalization, and sense of ineffectiveness at work. So low sense of accomplishment. And this happens to medical students, it happens to residents, it happens to physicians, it happens to nurses, it happens to lawyers, it happens to business, but it happens much more frequently to physicians than to any other group. When people have talked about burnout, or the literature you'll read on burnout, it will talk about, when it talks about total numbers, it talks about at least 2 out of these 3, so not necessarily all 3. If you look at all 3, the rate of burnout is about 30%. And so this is a paper from Tanis Schenefeld, who's at Mayo Clinic. He's an immunologist he's an oncologist who got interested in this and has done most publication. And I point out to you, neurology is fairly high up, but we're fairly close to dermatology. Who knew? So if you look at, this is the gold part is from the previous survey 4 or 5 years before that, and blue is for the most recent 2015-16 survey. And again, all specialties have had more people going or having burnout. And the numbers, if you look at, it's about 40 to 50%. Is that an overestimation? Probably. But it's a real problem. And it's a real problem that has an impact on both on clinical care as well as on training of people. Because if you have somebody who's burnt out, who's really not interested, has a lot of cynicism, really doesn't care, it's really going to impact your training as well. So with that, I'm going to move on and talk a little bit about how we monitor some of these things. And again, when you think about the learning environment, it's important not to just think of students, residents, and faculty. There are other people in that process, the staff that you work with, whether it's the administrative staff or the hospital staff, and of course patients, which are critically important. And I showed you this slide earlier. So in about 2007 or 8, we realized that we really do not have any substantive policies related to, I keep getting stuck in this thing, to professionalism. And having been here for about 20 years or so, I knew this was a challenge and a problem, not only for our faculty, but for our students as well as residents. And so I was tasked to come up with a policy. And I looked at the literature, reviewed whatever was available. We drafted a policy, we developed a consensus. We developed a consensus with the hospital leadership as well as the faculty. It was approved by the dean and it was implemented. And we have done periodic and deliberate reviews of this policy with our legal colleagues and others to make sure that we have a sustainable policy that's fair. And the most critical parts of any policy, and a lot of you who are in the administrative, like Dr. Klashinsky or Dr. Brickman, who've been involved in this process, understand there has to be a uniform implementation of the policy. Nothing will work if you tell Dr. X to do this and don't say anything to Dr. Y, and so on and so forth. So since we've been responsible, we've tried our best to make it a uniform policy, irrespective whether it's the chair of a department, whether it's a junior faculty member or somebody who's very productive, doesn't matter. If they've done something, they've done something. The other thing that, again, that's more for faculty, there has to be congruency between that policy and the medical staff policies, because what governs medical staff policies is sometimes different. That's a discussion for another day. The implementation has to be from the dean's office. It has to have some clout. It can't be the most junior person in the office trying to fix this problem. And again, the review has to be timely, it has to be rapid, and there has to be a tiered decision making. And what that means is that you have to the punishment should fit the crime. So if it's a minor first-time offense due to some personal issue, there you can give them some slack. But in other situations where if it's egregious and it's consistently happening, then it needs to be dealt with more severely. And this is important. And again, with Title IX, there are some changes in the process at the institution, and that's dictated by federal policies, and it's outside our control. But again, things like discrimination or sexual harassment are immediately reported to the Title IX officer. Other issues are typically dealt with in-house through our mechanism. So what's the process? So we've created a professionalism policy with a professionalism behavior report form, which is submitted to either an associate dean or any faculty for that matter, whether it's clerkship director, residency program director. Then whoever the responsible person is, which now I would happy to report is Dr. Duggan as Associate Dean for Faculty Affairs, will meet either with the student, which typically would be the one of us, and the faculty, ultimately with the faculty member. And then we typically, for faculty, for due process, we have a professionalism review panel. And again, then the recommendations from that are forwarded to the dean, and they may lead to some disciplinary action. Now, one of the things that students and trainees have to recognize, when that process starts, that process becomes opaque to you as trainees because there are some rules governing faculty that we cannot disclose a lot of the details of the investigation, but the outcomes and so on quite often will get back to people if they are named in that report. And then we can talk about that. This is what the form looks like. It's attached to the professionalism policy. And I'm not going to spend too much time on that because I want to leave some for questions. So we do have other mechanisms to report, which is through a dashboard, and I'll talk a little bit about what that dashboard, and this is primarily for medical students. As a result of the policy, what we noted was that there was increased reporting, which is what we wanted. And as a result of those increased reporting, we were able to address some of the issues that had been lingering for a period of time relatively quickly. In other situations, it became very obvious that there were some systemic issues that were addressed. Sometimes leadership changes had to be made, and all of those difficult decisions were taken. And we noted at least in the initial phase of the first few years, an improvement in outcomes based on graduation question and residence survey, and I'll show you some of that data as well. But there are other mechanisms by which we assess the learning environment. These include our clerkship evaluations, as I mentioned, the professional behavioral policy. There is an annual learning environment survey that we have students do kicking and screaming, but it's very important. We also do a look at the graduation questionnaire because there are specific questions related to that. And we also ask our program directors who have our graduates at the middle of their first year questions, and I'll show you some data on that. So how do we improve the environment? There are other ways to improve the learning environment that are specifically geared towards identifying good role models. So white coat ceremonies, orientation sessions, having sort of fair policies and procedures, honor code, and so on are examples of where clearly delineated behaviors that are expected are listed. And then in our courses, we have to have mechanisms to assess that. There has to be a formal curriculum, which we have in different segments. There you can use problem-based learning or other ethics courses for that. There also has to be a recognition of where the hidden curriculum is tripping us. And of course, the most important is role models. So having good role models, whether it's amongst your peers or students or residents. We do have a fairly active Gold Humanism Honor Society chapter here. We were one of the first schools to develop one. And we have a lot of wonderful students that have been part of that process. There are faculty and residence awards given which clearly recognize people who have reached a high level of humanistic medicine. I'll give you an anecdotal example. Neurology has been fortunate to have a lot of residents who have received the Humanism in Medicine Award. One of our residents who is very bright, but also a very, very engaging individual, won, I think, 2 or 3 years in a row the Humanism Award. Was it 2 years, I think? Jay, I think it was 2 years. And when he went to interview for fellowships, and he ended up doing a neurophysiology fellowship at Mayo, that was the first thing that they noted in his CV was his Humanism in Medicine Award, and that was a big deal. Now, he would have gotten anyway, but that was certainly an icing on the cake. So clearly those things matter in terms of outcomes as well. We also have challenges. We have different ways of assessing professionalism. Is it perfect? No, it's not. There are a lot of gaps, a lot of issues. It's subjective, and there are a lot of ways that one could be critical of that. But that's the best we have. We have assessment tools, especially patients, and for resident 360-degree evaluations are really important for that reason. This is a typical evaluation form for students. It's busy. I don't want to spend too much time on it, but I want to show you that when we originally developed the form, there were 4 segments in it: professional attributes, self-improvement, relationship with patients, and interpersonal relationship. Clearly, the most detailed part of that evaluation form was professionalism, because that was one thing we really wanted to drum home that this was important for people to recognize. In our new clinical evaluation form, it still exists in the same way. It's considered a competency, similar to ACGME competency, and again, it's recognized as important. So it's not gone away, it's just morphed into a slightly different form. We try to educate students at different parts of the curriculum. We need to do better. I think there are a lot of room for improvement, but certainly things like periodic communications or the honor code society and all those are important. Hopefully students don't come to promotions committee for professionalism violations, but that is known to happen. Now, another thing that I neglected to say, but I wanted to say, is that when we developed these policies, we developed the professionalism policy for faculty and students simultaneously, and it's exactly the same, except for the process. And that was deliberate and intentional, because again, as I said, what you don't want is a different set of rules for one group of people and a different set of rules for others. So the expectation from faculty is exactly the same as the expectation from students. So it's not like the faculty get a free pass on some things and not on others. And again, that form you can look at a later date. Now, we periodically also survey the learning environment, and I want to drive home a couple of points. This is what the form looks like, and students have to fill this out once a year. And there are different questions they're asked. They're asked about appropriate boundaries, classmates and treated respect, and they're asked about faculty, residents, nursing personnel, other hospital and clinical support staff. Regards for diversity, conflicts, professional language, honesty, integrity, atmosphere conducive to learning, development and understanding of my responsibilities as a medical professional were promoted. So this was typically given at UT until last year when we started moving more people to Toledo, and we do it both. And so this is, again, just to give you a flavor, it's a busy slide, but it does tell you a number of different things that we looked at in different sections. And one of the things we noticed, and I'll come back to that in a second, was that our responses to nurses staff was low for our students. And this is a score of 3 out of 4. And they were sort of hovering around 3.1 or so, which is quite low. It improved for a year and then went down. And so we had a very extensive conversation at the Executive Curriculum Committee. We talked to the hospital leadership. We talked to the nursing leadership. We talked to the coordinators who helped organize more opportunities for student interaction with nursing and nursing interaction with students. And that has gone up substantially since then to the level where we would expect it to be. So sometimes interventions do make a difference, and that this was a good example of where we used the tool that we had and made changes appropriately. We've also compared the learning environment at Toledo Hospital, and you may not be able to read it, and the environment looks extremely positive, at least for the first year. The next set of survey will be done in the next couple of months, and we'll have that data available for you as well. So right now, the data on both our hospital looks pretty positive. Again, same kind of issues with the question were treated with respect by nursing staff, and again, that has gone up. And some of it has been issues with misunderstanding of roles and so on and so forth, and other issues that we have addressed. Now, I mentioned the term dashboard, and what do I mean by that? And so this is, again, for students in the room, but for faculty to be aware of. We developed a tool in 2009 and 10 which looked at real-time data. And what I mean by that is that if you do these learning environment surveys or do you do end-of-clerkship evaluations, they're done in specific periods of time. And what happens is that if something is happening right there and then, it's missed. So we needed a sort of a real-time tool to be able to review this relatively quickly. And so we developed this online tool which looks like this, and the links are available to all students and are sent to them periodically. And it asks them the same questions that we have in other form, and there's a checkbox here that they can mark that, and it will automatically come to our office or to my email for attention. It also has the ability to look at specific people that may be involved in that incident, where it occurred in the hospital, and when did it occur in the hospital. And again, most of the comments, and this is from a little while ago, but most of the comments are positive, which is good, because we need to recognize good behavior as well as bad behavior. But there are some egregious issues or some other issues that come up, and then we address those. Now, if they're anonymous, we have no mechanism to, well, there's always a mechanism, but we do not intentionally track down who's provided that information. So we have no way of letting people know unless they put their name with the report. And either way is fine. So if you put your name with the report, we'll let you know what the outcome of that assessment was. But if you don't, that's fine too. We'll deal with the issue. So sometimes the students may feel that there's not enough being done, but at the back end of it, a lot is being done for that reason. And it's just that you're not aware of it because we don't know who you are. So we investigate. There are a lot of situations where there are comments like, Dr. So-and-so was a wonderful resident. He or she taught me how to do suturing and so on and so forth. So what I do with that information is I send it to the program director and the chair of the department, as well as the resident, if that's a resident, if it's a faculty member, to that faculty member, because those are the positive things that we have to build up on as well. So that's how we sort of look at real-time data. So that's another opportunity for people to provide information. And I mentioned to you our surveys. And so one of the surveys that we typically do is send it to program directors around this time of the year, to our graduates, to programs where our graduates have matched for residency, and ask them to rate our students, now residents, in the upper, middle, or the lower third. And what we find is that the vast majority in professionalism are ranked in the top third So 75% are ranked in the top third, 22% in the middle, and the 3 to 5% in the bottom, lower third. We know exactly who those folks are, by the way, because they've come up to our office for a variety of reasons. So, and I'll finish off with talking about that as well. So typically, bottom line, our students are extremely professionally capable and are recognized by the residency programs as being that. Cultural competency, which I didn't have time to talk about, but is also an important component, is also fairly highly rated in our students. So again, our residents are being recognized, our students are being recognized as being some of the best in their programs. And I'll come back to this sort of model that you sort of want to build for yourself and think about how you envision professionalism. Now, a couple of interesting points. So can we predict who's going to do well and who's not going to do well? And interestingly, there is some data that actually you can. And the domains of unprofessional behavior that always have stood out in medical schools that have identified these are poor reliability and responsibility. If you think about the earlier slide when I asked about, this was a completely different group of people that were asked about what they want in their PGY1 residents. Responsibility and reliability was number one. That's what's missing in a lot of these folks. Lack of self-improvement, lack of insight into their problems, poor initiative and motivation. When we interview people for residency, they always ask, what characteristics are you looking for? And my response is, you may be very good. We would love for you to be interested in neurology, but we expect you to be the best professional that you can be, because that's a deal breaker in my estimation for people. And why is that important? There's a paper from New England Journal of Medicine that I give to a lot of the students. It's a paper that looked at disciplinary action by state medical boards, and they went back and looked at if these people had any issues during medical school or training. And it turns out that they did. So people who had unprofessional behavior in medical school were 3 times more likely to lose their state medical license. And the things that led to that were things like severe irresponsibility, and that means recurrent episode of irresponsible behavior. They could start off with something like not keeping up their immunization status, not doing all the responsibilities that they were given in a clerkship or in a course, and that they lacked the ability to self-improve or self-control their performance. And so if they had no interest in improving or sort of always had an excuse for it, these are the ones who ended up losing their license over time. So back to the future. So now medical schools have suddenly realized that maybe they're picking some of the wrong people in medical school. And we're not talking about you guys. So just generally what we have always looked for. And the residencies have not caught up with this fact because they're very score-driven processes in most cases, is that there are some characteristics of individuals that I've alluded to about humanism and so on that really drive success. And our interviewing process, our selection process, our understanding of core personal competencies is perhaps not where it needs to be. And that's sort of something that's been debated in our admissions committee, by our admission leadership, by our deans, and so on multiple times, and it's sort of being looked at. And actually, this is probably the last paper I'll talk about. This was a paper in academic medicine that looked at what are the core competencies we should be looking for at the time of admission. And these are listed here pretty clearly. Again, same sort of concepts: ethical responsibility, reliability and dependability, service orientation, social skills, capacity for improvement, resilience and adaptability. And this is sort of very important. We find, at least, and this is again anecdotal experience and my experience, that students that have limited, or trainees who have limited ability to adapt to changes or have ability to adapt to new things are the ones who complain the most and actually turn out to have the most problems. Cultural competency being recognizing differences from others. and communication and teamwork. So those are the skills that actually we need to look for in our admission process. And we've sort of revised the process to do that much better than we had in the past. But are we there in terms of nationally or in school level? Perhaps not, but we are headed in the right direction. So in summary, I gave you sort of hopefully an overview of a complex system that multiple factors that impact it. It not only impacts personal well-being in terms of your burnout rate and so on. Humanistic physicians or physicians who are considered to be humanistic actually have the lowest burnout rates because they enjoy what they do and they are able to navigate those stresses that some people are unable to. And it is our duty as faculty to nurture a positive learning environment, and that we have to be advocates for our students and our residents in that process. And we have to have mechanisms, which fortunately we do, to incentivize positive behavior in trainees, staff, and faculty. We need to identify those tools to implement to understand and deal with the issues. We have noted some improvement in our overall in our learning environment, but we still have a lot of room to go. We will follow the AAMC outcome data, and when you get access to that data, you should also look at that and identify ways to improve that. And I'm going to stop here and ask if you guys have any questions. Yes, sir.
Well, yes, thank you for a wonderful presentation. I do have a question regarding the policy for faculty professionalism assessment. A few questions. Is there a regular annual review of professionalism for every faculty member? Does every faculty member have a file that covers this issue? Is each faculty member told when an item goes into their professionalism file? And so those are some questions.
Yes. So excellent question. So there is, as you can imagine, it's very hard to reach each individual faculty. So other than sending out emails about this and informing chairs and these kind of sessions, faculty information may at times be sparse. I grant you that. This perhaps is not as good as it should be, but we'll address that. When it happens, it is addressed. This is not peer protected. So this is not like a medical staff investigation. So it does go into their file. And we made it a point for it to go into their file.
The faculty is told every time that happens.
Exactly. Okay. So it's not like it's hidden from them, but if it happens, yes, it is. And so, the promotion process also will be impacted by this, as you know better than I do now, that there is a section in our promotion process where we have to identify any professionalism violations that are egregious enough that require intervention, and people who have had repeated events. Now, one-time event, as I said, sometimes may be sort of an error of judgment, but multiple events and some are picked up by others quite quickly, especially in our evaluation process.
So thank you. So
yeah.
Just to be clear, so
yeah.
Professional review only takes place if there's an instigation, there's a reason.
Correct.
Okay.
Yeah, absolutely correct.
Maybe, Jim, you're referring to the Vanderbilt system.
Well, that's a hospital-based system. So that's a difference. That's a clinical system, and it actually does not specifically address. It does assess disruptive behavior and so on, but it's a different process. It's a peer-protected process, so it does not go into their file unless it gets reported out. Yes, you had a question? Anybody had a question? Yes, Dr.
Well, congratulations. This is the first grand round with the department.
Thank you.
You've done a fantastic job and bringing to light some of these very important issues. I mean, I'm sitting on the executive committee, and to me, the biggest issue that comes up is this question of empathy. How do students nurture their empathy with it, come here with it, not lose it, and how do physicians train those students continue to exhibit empathy? You would hit on that point very solidly.
Thank you, Dr. Manning. Thanks for your support. Anybody else? Yes, sir.
The empathy and the psychological setting of the students coming in, is that at an unrealistic level to begin with And are they then coming back down to a more realistic setting, or is it realistic to begin with, and then they're becoming jaundiced?
I have the same question.
Yeah, that's actually good. It is the latter. It is the jaundiced part. So it's not at the, perhaps to some extent, but the drop is pretty significant. Yes, sir.
I'm not well read on the empathy literature. My wife would probably agree to that. But when it comes to other, it's similar to this other question. When it comes to other professions, so veterinary medicine, dentistry, law, how do those curves look when people actually get into their studies?
It's an excellent question. They're better than ours. So that has been looked at. It's better than ours. So other healthcare schools also see it, but not such a substantial drop as do medicine. So nursing school may have some, but not as much as we do. Yeah.
I just wonder, is there any literature regarding student awareness of this process? I mean, have you stumbled across, do they know that they're becoming jaded?
Yeah, I think it's a good question. So yes, so a lot of the studies were self-reported. So there were, other than the fact that scales are sort of blinded, so they don't know what that scale means. But there are students who are aware of it, but there are some students who may not be aware of it. So that's a valid point.
Is this, do you think, related to the overwhelming environment during their studies? Does this index improves as they start their practice after training? The empathy?
Yeah, so that's a good question. So I don't know the answer to that question, to be honest with you. I don't think I looked at that specifically, but that would be an important question to ask. Has it come back to normal or what the expected level would be? And the answer to that is, if that was the case, we wouldn't have such a high number of issues with medicine that we have with burnout, with safety, and a lot of this. A lot of it is tied to how well you practice. I mean, obviously that's not the only explanation, but that may be one of the explanations. So, don't know.
And so in that context, is the level of empathy when the student comes in directly or indirectly related to the burnout rate? That is, are they more more susceptible to
They're more
burnout because of the higher rate?
Correct. Yeah. Now nobody is.
Effectiveness.
Yeah. No. As far as I know, nobody's done that one-to-one comparison. Maybe worth doing, but that certainly is the case.
And did it vary depending upon which specialty the student chose later on?
So what, empathy? Yeah. So that wasn't one of the slides. So people who were going into technical specialties had lower. Now you have to be a little careful because at the time of first year, everybody wants to be a neurosurgeon and orthopedic surgeon, and then then things change when as they get modified. So third year is still a little early for people to know. But in trainees, like in the Stanford data for looking at disruptive physician, they were more likely to occur in the OR setting. Now, could you extrapolate and say, well, that's because all the surgeons are misbehaving? No, it's not the case. They're very good surgeons as well. But it seems to be slightly more in the technical specialties, for whatever that's worth. Now, there are a lot of internists and neurologists and others who misbehave too. So, who knows? Yes?
I was just wondering, is there anything, I know there's data on physician burnout and specialties and things like that. Is there anything correlating physician burnout to student empathy loss?
Indirectly. So indirectly at this point, I don't think people have looked at that prospectively. We were actually one of the sites for one of the data I showed you, one of the studies from academic medicine was looked at a validated learning environment survey, like the Jefferson Empathy Scale, and I still have that data, but it's blinded data, so I don't know. So tracking students into residency has not, as far as I know, not been done. But that would be the next logical step.
Comment.
Yeah.
Interesting that not to pick on surgeons, but surgeons have some of the highest unprofessional behavior reported, but their burnout rate was lower than average.
Yeah. And and the difference between the high and the low burnout rate is 40% versus 30%, or the difference is there, but I'm not sure it's that great a difference.
Something going on in the OR I don't know about.
Well, dermatologists and ophthalmologists have high burnout rates, so I don't know what's going on.
I think one of the key things that came up there is the question of satisfaction from your work.
Yes.
And I think that's probably the most elusive thing to get as a student. I mean, when you're a student, it's your grades. That's all they're interested in. But then, being a physician, taking care of patients, sometimes you can't see the work that you do and how you impact the patient.
Yes, yes.
And this is very important. There has to be positive feedback all through your student year and all through your post-student year.
Yeah.
And I think that's what's very critical for this profession.
Yeah. And I think the nice thing is that, you know, I've found students to be very insightful and residents as well, because I may be doing something that I don't particularly care about, or I shouldn't say care, but I don't know whether I'm doing it well or not until somebody points it out to me that, you know, hey, maybe this was, or somebody else says, you know, what on earth were you doing this for? So so you're absolutely right. Until it's validated, it does not resonate. And again, being satisfied with your work is critically important. So when people come to me and ask me for career advice, that's exactly what I tell them, is that you got to wake up excited about where you want to go to work. If you're not, then you're in the wrong place in the wrong time. So, yes, Dr. Duggan.
Briefly, I think this is one of the reasons why when we see these rising rates of physician dissatisfaction due to electronic medical records and other things, we really need to take that very, very seriously with our work environments, because this could have, this will have significant consequences downstream. And most studies are showing there was some horrible study that said something like 40% of physicians that were age, I think 15 above, would not choose to do it again.
Yeah, and that's from the same set of data, and again, so whether it's like self-reporting is just a little worse than it actually is, who knows? But I find it hard to believe that half of the physicians are burnt out. Maybe my threshold is different, but there is a substantial amount of burnout. It's not. Suicide rates in physicians is higher than a lot of other groups. Clearly, that's always been the case, and you can hear Dr. Grubb's presentation on that. There's huge amount of data. The incidence of depression in medical students is higher than the control population. I'm sure that would be true for residents and faculty as well. So I think there are a lot of different issues. Finding the sort of right things that make you happy. So as you go out, just look at the wall, which has the Gold Humanism Awards. And you may recognize some of our previous faculty members and residents who have received those. And so celebrating those, recognizing those is important. Dr. Gahar is there. It was an award, so she had to be there. So she won most awards. So this is a great role model, right? So any of the medical students, residents, Dr. Gahar is your ultimate role model. So if you can just be half as good as her, you got it made. So, all right, thank you very much.